Hi, I'm Dr. Duane Mellor. I'm an Associate Dean in Public Engagement in the College of Health and Life Science. I'm also a Senior Lecturer in the Medical School and a dietitian by background. I'd like to sort of welcome you to our conversation today, and I'd like to introduce my other sort of colleague, Dr. Sri Bellary.
Hello.
Would you like to introduce yourself?
Yeah, I'm Sri Bellary. I'm a reader in Aston University in metabolic medicine, and I'm also a consultant physician. I work at University Hospitals, Birmingham, and my specialty is endocrinology and diabetes.
Which brings us to the conversation for our Aston Original conversation today on health matters within the College of Health and Life Science here, which is around diabetes, around World Diabetes Day, and some of the great work we're involved with here at Aston, and also how we're trying to tackle some of those really cruel inequalities in terms of healthcare that we see with diabetes and how that affects people living with diabetes, but also some of the things we're trying to do with that. I understand, Sri, that you've been doing some really interesting work looking at young people with type 2 diabetes because, from my training, I know that type 2 diabetes was something that was generally associated with aging. What's your experience of working with younger people with type 2 diabetes?
You're quite right, Duane. So we have a very interesting multi-ethnic population in West Midlands, and the prevalence of diabetes varies quite significantly between ethnic groups. To give a idea, so if you are from a South Asian background, you're 4 times more likely to get diabetes, and traditionally, type 2 diabetes is a condition that often appears mostly over the age of 40, and that's what being taught in schools and medical schools for a very long time. But what we have noticed is that it's no longer a disease that occurs in middle age and older age groups, but it is tending to be more common now in younger age groups as well. In fact, about say from the ages of 15, 16 onwards, so we seem to be diagnosing type 2 diabetes, which we didn't do before, and the numbers are increasing disproportionately. So if you take diabetes as a chronic disease and the lifetime risk of getting complications of diabetes over time as someone lives, say, for another 40, 50, 60 years, then the earlier you get diabetes, there is a greater risk of these complications as well. And we really have to be very concerned that many of our youth are getting diabetes that early. So at Aston, we have started some research around this area. We have already characterized youth with type 2 diabetes to understand the risk factors that are contributing to it. But we are also trying to look at wider aspects of it. So, for example, how does it affect quality of life? What treatments work? What should be the best care of medical care that these people should receive, and how is it different from type 1 diabetes if we get early? So yeah, it's quite a very expansive program that we're trying to do at Aston.
And you're saying about the risk factors. Are the risk factors different between type 2 diabetes in young people and young adults compared to type 1 diabetes? You've mentioned about ethnicity. Does it link with any other factors that we see here in the West Midlands, such as household income, levels of deprivation, those sort of things?
Yeah, very, very good question. So if you actually look at the risk factors for type 2 diabetes and younger onset type 2 diabetes, I think there's a lot of common features there. So, for example, obesity is a risk factor across all age groups. But what we do see in younger people is the clustering of these risk factors. So often it's more than 3 or 4 risk factors occurring in one particular individual at any given time. And that disproportionately pushes them towards having diabetes very early. And that tends to be say, a bit more common in people of, say, minority ethnic groups. And also, deprivation links in very, very much within this whole risk factor conundrum. So, if you have, say, are belonging to a certain ethnic group and also or socially deprived, then the clustering of these risk factors actually exaggerates the risk, and that's exactly what we are seeing in younger people. But obesity clearly is the underlying theme.
Okay. And you're saying about sort of these risk factors about ethnicity and deprivation. Does that act as a barrier for people seeking help as well? Because we know in areas of affluence, people are more happy to go and see a doctor about health conditions. Does it have an impact with younger people living with type 2 diabetes?
I think it does, but we haven't been able to examine that in detail, but it certainly does. So if you belong to, say, a deprived area, for example, you have less access to certain say even healthy foods or abilities to exercise, and at the same time less likely to access healthcare as well. And there's numerous studies in the past which have shown that if you come from, say, deprived areas, then you're less likely to access healthcare or seek help early. So that feeds into very much into the context that people do not anticipate those risk, and therefore they do not get themselves screened or checked, and as a result, maybe sometimes the diagnosis is late or doesn't happen from when it actually should happen, and then they don't get the intervention they need.
And you mentioned about some of the work you've been doing is looking around improving healthcare and access to healthcare. What sort of things are you working on at the moment in this area?
So one of the things we are looking at is to try and see if we can define these risk factors better. So can we use general practice data to identify those at most risk and then invite them to be screened for diabetes? We are also trying to see if we can identify, say, family members of those who have had early onset diabetes, to see if we can proactively screen them, because they are at the most risk as well. So in terms of access, I think it's a bigger challenge. So the way we are going to is by enhancing the, say, the communication around diabetes, talking about diabetes a bit more within the communities. In the past, we have done lots of sessions, say, in mosques and gurudwaras, and trying to increase the awareness amongst those populations. But it's still amongst the youth, it still is a challenge because they move to, say, for example, to universities in different places. They often don't think about diabetes as a likely thing that could affect them. So it is a little bit more challenging, but we are trying to create more awareness around this, and certainly even nationally now, there is increased recognition about the risks in youth, and they're trying to create more awareness around this.
So just thinking about sort of young people with type 2 diabetes and risk of young people, and bear in mind our great diverse cohort of students and our alumni of Aston, and we're doing a conversation today. Would you like them to spread the word that diabetes and type 2 diabetes does affect young people?
Yeah, of course. I mean, that's it. Obviously, the student population is a very good cohort to talk about these risks. And yes, we need to make them aware that type 2 diabetes can occur in any age group, particularly if you are of a South Asian or Black ethnic minority group. And if you have a family history of type 2 diabetes, then there is a high chance. So if you do have symptoms or if you are worried about it, you must seek help. But that certainly needs to be communicated well within the student cohorts.
And another thing you talked about was medication. And I know we've written recently about some of the new medications that are not just used in type 2 diabetes, but also used to help people living with obesity. Is it okay if I have a conversation about some of the challenges that we're having with those and some of the interesting ones? So does it excite you that these new drugs that are coming out that could help people living with diabetes?
Yeah, of course. I think there's been quite a lot of improvements in diabetes care, and one of the areas where we have had huge success is some new therapies that have come about. Conventionally, we know that people with diabetes, controlling sugar is one of the main things, but that came at a cost. For example, if you went to sulfonylureas or insulin, that often caused low blood sugar called hypoglycemia, or it used to cause weight gain, which is paradoxical because we want patients with type 2 diabetes to actually lose weight. And if you're giving a drug that's going to cause them weight gain, it wasn't an ideal situation. So now we have, at least two classes of drug I can mention. One is called it's a bit of a mouthful, but it's called SGLT2 inhibitors or gliflozins. The other is injectable solid GLP-1 agonists, or incretins to be more broad as such. But these drugs have tremendous benefits. They lower blood sugar, but also help you lose weight and improve the cardiovascular and renal risk factors. So I think they have been shown to be extremely beneficial. Now, the one which you're referring to, the incretins or GLP-1 agonists, I think they have had tremendous success again. The amount of weight loss that we are now seeing with some of these preparations is highly encouraging. In a clinical context, you would say a 5% weight loss would be considered to be highly significant. Whereas some of these medications can give you 10, 15, and even 20% weight loss. From that point of view, it is encouraging. And of course, for patients with diabetes, this could be a game changer. Very much um, an exciting development in the field of diabetes.
And from a dietitian point of view, I've done work in type 2 diabetes and guidelines, particularly around this idea of concept of remission or mitigation of the glucose levels to get them from their diabetes levels, which are high, back down to normal levels. And it's often talked about sort of 15%, but we generally think of people being around 100 kilos, so that'd be 15 kilos. That's been shown to reduced the chance of someone being diagnosed again of having type 2 diabetes being put into remission. We don't call it cure because we know that some of the complications you've mentioned because of the diabetes can affect the eyes, the kidneys, the feet, the circulation. It's not safe to say it's been cured, but it puts some of the biology back to normal, so their glucose levels are set and it reduces their risk long term. And I find it really interesting that, it used to be that weight loss and you had to eat a low-fat diet was the only message. We now know there's a whole range of dietary approaches. The work that was done in Newcastle and Glasgow used shake meal replacements to get a 800 calorie a day. The work we looked at was looking at low carbohydrate diets, so reducing the carbohydrate, which reduces the need for the body to make the hormone that controls blood glucose, something called insulin. So it may be just pushing things down, but generally they lead to weight loss as well. And sort of working with sort of medical colleagues around the country looking at their data, it's quite impressive. I think the key thing we need to look at is the diet that works for someone, along with the medication that's appropriate. It needs to be a way that they can live with long term, because as you've said, diabetes is a long-term condition. So it is getting the right fit for the right person. And I think that can be difficult if someone's coming from, as we were talking about earlier with some of these young people, they may not be from backgrounds where they seek healthcare, and from some of the areas within our city where they've got greater levels of deprivation, they may not come and they may not engage with a health professional in a way that gets a health professional thinking about new treatments. Or they may go to the health professional and just go, I'd have that, just take the treatment given, rather than thinking, I've heard of something new. I know that my weight's a problem. I know that I'd like to consider managing my weight. And how do you think we can have better conversations as health professionals, and also training the health professionals like we do here at Aston, to engage people in sort of that shared care approach and looking at the best way of managing their diabetes?
I think you make several good points. Firstly, I think you touched upon the diet, which very clearly has shown that if you help people to make significant changes to a diet, in that low-calorie diet, and the example you gave from the study from Newcastle, so it can potentially reverse diabetes within, say, if you have had diabetes within the first 3 years of diabetes, that's possible. And there is now a program nationally which has enabled some diabetes reversal clinics, where through the NHS we do offer that. And similarly with the other treatments, which we've discussed, including the weight injections, which help with weight loss and improving blood sugars. The main challenge is that, yes, there are still huge inequalities. Again, you touched upon it, that people from certain backgrounds don't come forward to ask this. And to a large extent, I think this is dependent upon the health professionals. We need to take responsibility of it. We need to engage patients in this conversation a lot more, trying to offer them the different choices that are available, and making sure that they can make informed choices. It may be that they still don't like a low-calorie diet, but that's fine. But at least they should know that such an option is available to them. And also we need to fight certain biases that inherently exist. We sometimes think that, okay, this patient is not suitable, we probably is not going to follow this diet, and we make assumptions, and that's probably wrong. I think we should, doesn't matter what the background of the patient is, that we should be very honest and give them the options. And to some extent, again, we also need to fight certain misconceptions. I mean, some people, in certain communities, if somebody has had a bad experience, that spreads pretty quickly, and sometimes you'll have to put the facts in front of the patient and convince them. So I think to a large extent, the health professionals have to accept that there are going to be differences. There are going to be perceptions which are different culturally and from ethnic groups, and try to address them. But we do have those. We are in a national health service that's for everybody, and I think we need to make sure that that kind of healthcare is accessible to everybody.
And I think it's really good in our community at Aston, both in terms of colleagues, but also our students are very diverse in their backgrounds, and sort of working with them, we're both in terms of within our different health courses, but also across our health courses, we're having conversations about how do you sensitively open up those discussions, because if you have assumptions that you bring as a human being, but you need to remember the person in front of you has those, and how do you break those down? How do you have sensitive conversations that sort of explore what a person would like to see, and break down some of those sort of cultural sort of constructs within that we can see, but also a lot of those we don't see, to have open and good therapeutic conversations, so we can really genuinely help people to improve their health, rather than just stick in sort of those closed mindsets, because diabetes is changing. Everyone's diabetes and everyone's experience of diabetes is so different. And I think one of the challenges we've got with some of these new drugs, these incretins, as we mentioned, these GLP-1 drugs, people may have heard of things like Wegovy or semaglutide and all these names and complicated names in the press, but they're now being talked about weight management rather than type 2 diabetes. Do you think with this discussion about weight management and some of the celebrity stories around that, it could be problematic because they may go to private prescriptions rather than those people who have already said don't necessarily access the NHS, but when they do access the NHS, go there and find that the drugs they need have been sort of moved in that way? And has there anything been done to try and make sure the right drugs go to the right people?
I think it's a challenge. There are aspects, as you rightly said, the cultural barriers or the constructs that already exist that needs to be addressed, and that the only way we can do that is by having open conversations about it and be able to discuss this. And students can play a very vital role, because it doesn't mean that they need to have diabetes to understand this, but the very fact that they are students and they are, say, for example, studying at a university, they're more informed, and they can spread the message within their families and communities as to what treatments are available, and perhaps challenge sometimes even the health professional and say, why is it my mother or my dad not getting this treatment? So that kind of conversation needs to happen. With regards to the new treatments, I agree. I think it's about prioritization. So who needs it most should be one of the considerations. So certainly, if we look at patients with diabetes, they are likely to benefit more, purely because they are essentially glucose lowering drugs. So it helps us to control glucose while also tackling obesity, while also tackling their cardiovascular risk and so on. So clearly, we have to make sure that the people at most risk should have it. Whether it can extend beyond that, and it is a matter of time, because you know it very well as I do, that these would be licensed for treatment of obesity as well. And I think that is going to cause increased demand, and it is a challenge because the industry would have to cater to these demands. Otherwise, you're right. I mean, it's likely that it would not be available for patients with diabetes, but end up being available only on private prescriptions, which is quite expensive and at the same time unregulated at times. So we have to make sure. I think the main challenge is who is going to control this, and to some extent the leadership should come from managers, leaders, and in conversation with pharmaceutical industry to make sure those at most risk should still be able to access it in the first instance. And secondly, we need to look at the broader aspects of patients with obesity. So if I may just add that we also need to address the broader question of obesity as well, because that's a precursor for many things. So I'm no way suggesting that people who do not have diabetes but are, say, of a high BMI, for instance, should not access these treatments. That these are treatments that would benefit them as well. But I'm just saying that there has to be a prioritization based on the risk.
And we need to sort of, when we look at the health inequalities and the unfairness, which puts people in environments where they're more likely to gain weight. The food access you've talked about, access to physical activity, access to opportunity. And we know people living in poverty have problems with the time pressure of having to work several jobs just to live. So the ability to be able to cook fresh food is a luxury which is not there. So that's a whole complicated thing. And I think sort of it gets chunked down, as you're saying, into different parts, which we can forget that we need to look after people with diabetes, but people living with overweight and obesity, we need to look after, and we need a fairer system overall. I think sort of a lot of the work we're trying to do through Aston and sort of the way we're sort of looking to widen both the scope of our research and looking at these inequalities, but also the engagement of students from different backgrounds, tries to get that sort of message across. And I think you made a good point, which we all forget as health professionals, is we learn all this stuff, we do all this research, we do all this teaching, but we've got to remember it applies to us, our families, and we've got to share those messages out so we can help create healthier communities. And it's one thing we possibly could do a lot more of. I think that leads us nicely to where we're going, because we've talked about humans a lot. A lot of these things about, and it gets complicated when you talk about inequalities, is technology.
That's right.
Diabetes for me is very much a human thing. It's about interactions and communication. But do you think technology's got a big role to play? We can look at wider, type 1 and type 2 diabetes, pumps, sensors. Where do you think we're going with technology?
I think it is. It's a very interesting and exciting period to be in with regards to diabetes and technology. Certainly in the last 10 years or so, the amount of technology that's come into managing diabetes is unimaginable. There's always going to be challenges in trying to get to grips with technology, but it is rapidly changing. But I think it predominantly has been extremely beneficial. It's the biggest thing, what we need to recognize is diabetes is a chronic disease, and you have to live with people live with that condition for almost several years, and until sometimes as long as they live to some extent. And they are the ones who manage their diabetes most of the time. There are studies which have been shown that on average, you probably get about 6 hours of time with a health professional. Maybe I'm even that's probably a bit of a generous time. But rest of the time they manage on their own. And technology has enabled self-management quite a lot. And some of these new devices, which you can strap onto your arm, and it continuously measures your sugar and feeds back that information back to your mobile phone, helps people make real-time decisions. And that has been shown to improve their quality of life, improve glucose control, and the convenience of not doing 6 tests a day just to check their blood sugars, and also warning them when their sugars are low. So I think some of that technology is now firmly embedded, and fortunately in the UK, at least for people with type 1 diabetes, we are able to offer that. But technology has moved even further with regards to type 1 diabetes. We now have hybrid closed loops, which almost function like an artificial pancreas, where it measures the blood sugar and also communicates with the sensor to release insulin proportionate to the blood sugar. And so that is transformed the lives of people with type 1 diabetes. And some of these monitoring technologies would be applicable even for people with type 2 diabetes. So I think it's going to change a lot in terms of how patients can look after themselves. The challenge is, can we afford this technology, and can we make it equitable? And I think that is where we are struggling at the moment, because the numbers of diabetes is increasing in every single year. So to be able to make sure that people with diabetes can get this treatment means that it needs to be backed up with lots of investment. And again, we see time and again, like in every aspect, that people of certain backgrounds are less likely or much slower to access these technologies.
I remember from working with people with type 1 diabetes is the decisions you take for granted because your pancreas is making insulin. Every time you decide to move, eat, drive a car, your pancreas is making decisions for you. And when you have type 1 diabetes, you have to think about that. So some of these closed loops or sort of these hybrids, they allow you to do some normal things, but then you still need to engage the person and do different education, because when you do extreme exercise like climbing a mountain, you have to adapt that system or even switch off that hybrid closed loop because you're doing something different. So it takes a lot of the day-to-day mundane decision making out, which gives people a break, because it is hard work having type 1 diabetes. And it's how it really helps. So I think the decision thing is important. One thing I think we tend to, when I remember looking at these data coming out of patients' pumps and devices, it creates a lot of information. So we need to prepare people to be able to manage lots of information that comes out of these devices.
Yeah.
And that goes for health professionals as well, because when you can be flooded when you've got a sort of a busy clinic and you've got all these graphs coming through, and you sometimes think, what am I doing with all these graphs?
Yes, absolutely.
You may have the luxury of a diabetes specialist nurse or someone who looks after pumps, but when you get all these data, it is big data, and we need to be more literate with data, both as health professionals, but also helping our patients to cope with it, and sort of that data you don't have to think about. That's back. These are the bits we need to focus on and be able to refine and pick out things. And another area I'm really interested in, sort of this is the concept of how we can use artificial intelligence, because diabetes needs a human aspect as well as the tech, and whether we can use things. And I'm involved in a project where we're trying to look at different groups with different language backgrounds who don't access education, and how do we build a safe AI system that can actually provide them information that they can talk into their phone, and links in between what they might get from a doctor such as yourself, GP, nurse, but doesn't extend beyond that. And is this the future? Is it risky? Is it benefits? It'd be interesting to know your thoughts on how we can sort of, what do we need to put in sort of that sort of device if we're looking at artificial intelligence to bring all the bits of information to help someone to translate it both into their language if necessary, but also message they understand without telling them to do something that might be dangerous.
Yeah, I must say, when we talk about technology, I feel that I've grown old. So sometimes I struggle with the whole concept of technology. And you're right. I mean, the amount of information that comes through, and to distill the one information that's most relevant is a challenge. So there are certain simplified messages that can be drawn from all this information, and that's probably what we need from a general day-to-day basis. But in terms of artificial intelligence, again, coming back to your point that there are so many decisions you make within the day, and sometimes you don't really think about it because your pancreas does it for you. But when you have type 1 diabetes, you're making those decisions, and so sometimes the decisions can be right or wrong, and those are the kind of the intelligence that needs to be gathered. So AI will have, I mean, obviously AI. When I think about AI, there's been so many algorithms, and I think that would have to work around and help the patients make those right decisions. But I think a significant leap, I would say, is going to be in the way AI can help individualize to that patient. And that comes into what you said, is that sometimes you don't understand, you can talk to in a different language, but it could still interpret. It can still work out as to what that particular person needs, because everybody exercises differently, eats differently, and has a different lifestyle. So how do the technologies adapt to the individual? And that's the level of individualization where the AI can be extremely useful, by trying to almost allowing the machine to learn for that individual rather than just work on a very universal algorithm.
And the challenge is trying to get it to where's the limits of what's safe, and then sort of building in between the gaps. And I think you described nicely, we've got this idea, this continuance of sort of living with diabetes, that you have, I think you said 6 hours. I think it's probably close to 3 hours from what I've read. And in between, you might have little questions you want to ask, which aren't the big questions you might think, I really need to know the answer from a specialist. But I just want to know, is a parsnip the same effect on my diabetes as a carrot? That simple little things, which could be, through a sort of a learning chatbot type model. And the other thing is using conversations. This will be available hopefully on the internet, which can then be drawn down by large language models to then inform others to do that. And things like capturing conversations, consultations, because when you're making a consultation, there'll be certain things, certain points you're going back and you're agreeing that, and you could possibly have that live on your screen after you've seen the patient at the end of the consultation, so it doesn't take any more time. And he goes, well, we've covered those 3 points more than anything. Are those the 3 things you want to work on? And it actually almost gives you an automatic thing that you can go to their device, and we can use AI in all these ways to improve consultation skills. We already have them in our sort of predictive typing sort of things, and really useful when you're spelling some of those drug names to make sure you get those right. But we can use these sort of technologies. The problem, going back to where we started, is some of the inequalities, because we know some particularly older adults may not be sort of accessing technology. Some people from the community we talked about may not have access to the technology, the type of devices to do that. So we need to look at that digital poverty, access to sort of
Absolutely.
connectivity as well. So I think, when we're looking at diabetes, we can't forget a lot of the problems and challenges we have with diabetes are down to inequalities and some of the unfairness in our society. So we need to push against those, but also push for a lot of these innovations.
I think you've summarized it beautifully. Yes, we would have to address these inequalities, and typically, I mean, diabetes is a huge spectrum, and we only sometimes take a very singular view of that and say that this is going to be fine for everybody, but it's not. And I think we need to be aware that across, say, age groups, gender groups, ethnic groups, socioeconomic groups, there are huge inequalities, and we need to think about that inequality when we see patients, so that can be properly addressed. But absolutely right. Until we do that, we're not going to be doing a great job with what we have.
I think we've had a great conversation. The two things I'm going to take away from this, and I'll ask you to give your final thoughts. One, I think we need to remember we know a lot about diabetes, and we need to share that more with the people around us, not just experts, not just our students, but share them with the community and encourage our students to do that. And the other one is we need to think about inequalities and challenge them, not just say, I can't do anything for that. What sort of closing thoughts do you have?
I think those two points are excellent. If I may add, I think we are at a university, we have the capacity and resources to advance our understanding and research. So again, encouraging students to come up with some bright ideas and think about innovative ways of, like you said, artificial intelligence is one thing, but it could be anything. But if you have a brilliant idea, come and have a chat, and then that's the way we need to go forward. So because ultimately it's the science that drives innovation and improvement, and we want students to be more engaged with these kind of things, because it is diabetes is going to be a huge health problem globally, and certainly even in the UK, it is going to be a huge problem in coming years. And we need more youth involvement, more students to be involved in various aspects of this.
I think you're perfectly right, and that's a nice way to close. It's an exciting time to be at Aston. Diabetes is a massive global problem, and that's why we're here talking about it on World Diabetes Day. And with the Aston 2030 strategy and the sort of that centre around communities, improving health, but also digital, we've got the whole thing, and sort of people should come and talk to us about how we can actually improve care and the background and the science behind care for diabetes. So I'd like to thank.
Thank you. It was a wonderful conversation. Thank you.
So I'd like to thank sort of people for tuning in and sort of looking at our conversation about diabetes. It's something we're passionate about, and if you're passionate about it or got questions or comments, please put them in the comments below. And if you're interested in some of the work we're doing at Aston University, please sort of look at for more information on our Aston Originals channel.